Hello friends, today we are going to discuss about ketamine in psychiatry. I am Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neuroscience, Bangalore. In this video, I'll be discussing about history of ketamine, mechanism of action, what are the indications for ketamine in psychiatric illness, availability of ketamine, and administration of ketamine in treatment of psychiatric illness. Ketamine hydrochloride has been approved for general anesthesia as a standalone or in combination with other medication. It is an effective drug for use as a short-term medical procedures that do not require musculoskeletal relaxation. Ketamine primarily interacts with NMDA receptors in the central nervous system as an antagonist. NMDA receptors play a very important role in regulating neuronal cell survival, long-term potentiation, and synaptic plasticity formation. Excessive NMDA receptor stimulation or activation is also detrimental to the cell. It initiates transcriptional shutdown of channels, leading to mitochondrial dysfunction and even glutamate overload, resulting in neuronal cell death, that is apoptosis. This is how ketamine chemical structure is. It is O-chlorophenyl 2-methylamino cyclohexanone hydrochloride. That is the chemical name of ketamine. Ketamine is an enantiomeric mixture of S-ketamine and R-ketamine as shown in the figure. S-ketamine has fourfold greater affinity or potency in blocking NMDA receptors when compared to R-ketamine. Ketamine was introduced as an anesthetic drug, but later it was used as analgesic and also now antidepressant drug. It has an high abusive potential and it has been misused in recreational drug, date rape drug, and also in combination with various drugs, it has been used as a substance abuse drug. If you look at the recent notification from the Government of India, ketamine has been included in the psychotropic substance under NDPS Act of 1985. That means this medication is highly regulated under the NDPS Act. Further, under Drugs and Cosmetic Acts, again one more notification came in 7th November 2013. Ketamine has been included under Schedule X of the drug. That means no chemist is supposed to sell the drug without a proper prescription, and once he gets the prescription, he will dispense the medicine and keeps the prescription with him, and he will store it for next 2 years. As and when the authorities ask for the proof of selling to a particular person. That means, my dear friend, ketamine is known to cause dependence and it has been abused and used by many people as a recreational drug. Hence, the governmental agencies across the world regulate the manufacturing, transportation, use, and also used for medical purpose. Let's look into the history of ketamine. The ketamine history has to be started with phencyclidine. Phencyclidine was synthesized as a potent anesthetic and a sedative agent in 1956. There was scientific research was going on to get the best anesthetic agent. At the same time, it should be sedative and also analgesic. Of course, phencyclidine produced a reliable sedation and potent analgesia. It caused severe adverse reactions such as increase in blood pressure, salivation, hallucination, excitement, aggression, and at times agitation. Above all this, prolonged duration of action caused phencyclidine to be abandoned. Later in 1962, Dr. Calvin Stephen found another agent which is similar to phencyclidine, which produced excellent anesthesia and was short-acting. Since it was a combination of ketone with an amine, hence it was named as ketamine. Hence a search for new molecule ended up in ketamine. Basically, they were looking for the derivative of phencyclidine. When phencyclidine was abandoned and they were looking for a similar derivative, and the researcher bumped into a ketamine, one of the breaking revolution with regard to anesthetic agent. If you look at this diagram, you can see phencyclidine was introduced in 1956, but however, it was abandoned, and later the derivative of phencyclidine, CI581, was introduced in 1962. The first human use was done in 1964. Let's look into those aspects of ketamine, how, where, and when it has been used. Let's look into this. As I mentioned, in 1962, ketamine was developed as a less hallucinogenic and more of anesthetic short-acting agent. In the 1964, Edward Domino and Dr. Carson first injected ketamine into human body and defined as a dissociative anesthetic agent. It anesthetized volunteers, and the volunteers reported a feeling of disconnection from the environment and floating feeling in the outer space, and there is no feeling of either arms and legs. That means there was a complete anesthesia and analgesia. This was a wonderful drug which was used for surgical procedure. Ketamine also produced profound analgesia without a sleep and anesthetic state, which may be due to a functional dissociation between thalamocortical and limbic system. This is called as dissociative anesthesia. Ketamine, principal metabolite being norketamine, also has an anesthetic effect. Later, the ketamine was approved for anesthesia, but during the 1970s, in the Vietnam War, it was used in the war ground where soldiers were need to be operated without looking into the aspect of anesthetic agent being respiratory depressive. Ketamine caused bronchodilation and did not cause any respiratory depression. However, it had a great analgesic power at the same time anesthetic agent. Hence, it was extensively used during Vietnam War. Further, the first trial of ketamine with regard to depression occurred in 2000. Further, S-ketamine and R-ketamine was tried in 2014 and 15, and finally in 2019, FDA approved S-ketamine for intranasal spray for treatment of treatment-resistant depression. Psychiatric indications of ketamine. Ketamine is primarily indicated in treatment-resistant depression. It may be major depression, recurrent depressive disorder, or BPAD depression. Ketamine is also used in suicidal ideas, suicidal attempt situation. In a scenario where a rapid resolution of depressive symptoms or deliberate self-harm symptoms to be controlled, ketamine is the drug of choice. Other indications such as PTSD, anxiety disorder, OCD, and in substance abuse has been indicated, but however, they are still in research. Let's look into the mechanism of action of ketamine. As I mentioned earlier, ketamine is basically an anesthetic agent. It acts by either enhancing the inhibitory transmission or blocking the excitatory conduction in neuronal impulses. Basically, it blocks the NMDA receptors, which are excitatory, and results in massive glutamate transference. The other important theory is neuronal network theory. Here, massive noradrenaline release because of overexcitation may contribute to the mechanism of ketamine anesthesia, which is indicated by increase in blood pressure whenever this ketamine is given. Further, The metabolite of ketamine, that is hydroxynorketamine and ketamine, has been found to be very effective in antidepressant activity. The disinhibition hypothesis of ketamine action proposes that an increase in synaptic glutamatergic neurotransmission causes an activation of postsynaptic AMPR receptors. Activation of both AMPA and NMDA receptors is required for long-term potentiation and synaptic plasticity, which has been attributed to antidepressant activity at this point of time. Further, ketamine rapidly increases the phosphorylation of hippocampal tropomyosin receptor kinase B and induces a rapid increase in total BDNFA protein levels. As we know, BDNFA, that is brain-derived neurofactor, plays a very important role in antidepressant activity. Transforming growth factor B1 has long been considered an exhibit of neuroprotective mechanism in the brain. Ketamine is known to increase transforming growth factor in the brain, my dear friends. If you look at the ketamine acting on various receptors, first and the foremost, NMDA receptors. Next is opioid system, that is opioid receptor, where it acts as agonist, and further in cholinergic agents, where in the system it acts as a nicotinic acetylcholine receptor, muscarinic acetylcholine receptors, monoamino system, where D2 and D3 receptor partial agonist, and also acts as a uptake inhibitor with regard to dopamine transporter. Further, it also acts as a 5-HT2 agonist and 5-HT3 antagonist. Further, serotonin transporter reuptake inhibitor. This is where how the ketamine acts on various receptors. If you see how the ketamine acts at various receptors, various neuromodulation effect, gene expression, and cellular effect. In this diagram, if you look at the hypnosis, it acts by blocking the NMDA receptors, that is N-methyl deaspirate. Further, hyperpolarization of activated cyclic nucleotide channels, acetylcholine receptors, nicotine acetylcholine receptors, and L-type channels, calcium channels are activation or blocking occurs. Further, psychotomimetic action occurs because of neuromodulation, that is increased glutamate, increased noradrenaline, dopamine, increased cortical acetylcholine, and decreased pontine choline. Here you can see there is also increasing and decreasing of opioid depending upon the stimulation. Extracellular signaling regulated kinases are either increased or decreased. Metabotropic glutamate receptors are also increased or decreased, and NADPH oxidase. Further, AMPR insertion and also NMDA phosphorylation and expression do occurs. Further, the gene expression, early gene expression occurs, GFP expression. Further, BDNF, MTOR, and RGS4 also found to be acting here. Here, MTOR is a mammalian target of rapamycin. RGS4 is a regulator for G protein signaling 4 and glial fibrillary acidic protein GFP. Further, cellular effect of synaptic hemostasis and apoptosis also do been found to be occurring whenever the ketamine acts on various receptors, neuromodulation, gene expression, and cellular effects. Let's look into the ketamine metabolism. Ketamine is a low plasma binding drug. It is approximately 10 to 30% of the ketamine binds to the protein. It is highly lipophilic. Since it gets soluble in fat, the storage of higher drug concentration is seen in the central nervous system, that is CNS, than in the plasma. This is especially with regard to R-ketamine. Ketamine undergoes a complex metabolic process which occurs primarily in the liver by participation of cytochrome C450 enzyme system. Following enzymes are involved in the metabolism. You have to remember, metabolism of ketamine occurs in the liver and excreted in the urine. Let's look into the various cytochrome C450 involvement of enzyme. Here you can see the ketamine at the right corner, where you can see that CYP3A4 breaks down ketamine into norketamine. Further, CYP2A6 breaks down into hydroxynorketamine. Further, you can see CYP2DB6 also plays a role in breakdowning of hydroxyketamine into hydroxynorketamine. My dear friends, you have to remember this. The norketamine and hydroxyketamine play a very important role as an antidepressant effect, my dear friends. Here, summarizing the metabolism of ketamine here, you can see 6,5,4 hydroxyketamine and 6-hydroxyketamine is broken down into 6-hydroxynorketamine, similarly 5 and 4. So, my dear friends, the metabolite of ketamine also plays a crucial role in psychiatric effect of this drug. Ketamine and the metabolite of ketamine, that is hydroxynorketamine, is found to have an antidepressant effect, my dear friends. Now let's look into how ketamine is marketed in India. Ketamine is available as a 500 mg per 10 ml vial. That is, this vial has per ml is 50 mg. But however, the dose to be given is sub-anesthetic dosage, that is 0.5 mg per kg body weight. If a person has 60 kg is the body weight, then you will be giving 30 mg of ketamine over a period of 45 minutes to get this antidepressant effect. You can see other availability of the ketamine is 1000 mg per 10 ml vial, 500 mg per 10 ml, 200 mg per 20 ml, 100 mg per 2 ml, or 100 mg per 10 ml. The administration of ketamine occurs either IV, IM, subcutaneous, intranasal, and orally. Here you can see the FDA approved S-ketamine, which is marketed as Spravato. This Spravato is a nasal spray which for treatment of intractable depression and suicidality has been indicated. This was approved in 2019 in US, my dear friends. Let's look into the effects of ketamine. The positive effect of ketamine, if you look at with regard to anesthesia, analgesia, it has anti-shock effects. Even if there is a bleeding, this ketamine as an analgesic anesthetic agent will not further cause shock. Anti-inflammatory effect. It has a bronchodilator effect, local anesthetic action, anti-tumor effect, neuroprotective, and antidepressant effect. All these properties of ketamine has been found to be useful in medical field, my dear friends. However, there are certain negative effects of ketamine: drowsiness, dizziness, nausea, panic attacks, anxiety, rarely seizures, hallucination, disorientation, dissociation, bad dream, illusions, hypertension, tachycardia, and cystitis. So these are the bad effects of ketamine. This diagram summarizes the both positive effect and negative effect. The positive effects are shown in the red, that is neuroprotection, antidepressant action, bronchodilation whenever you want to give it for anesthesia, increased analgesia, decreased hyperalgesia, acute tolerance is very less, analgesia is very good. Further, it is very essential as an anti-shock agent, anti-inflammatory, and anti-tumor activity. The negative part is seizure, psychoreaction such as hallucination, bad dream, tachycardia, hypertension, and cystitis in ket abusers, my dear friends. Let's look into the bioavailability of ketamine. The bioavailability of ketamine depends upon the route of administration. If you look at the intravenous, the availability is 100%. With regard to intramuscular, it is 93%. Intranasal varies between 8 to 5%, my dear friends. With regard to oral, it is 7 to 29%. Sublingual maximum is 30%. With regard to subcutaneous, again, it is 90 to 95%. So if you look at this table, my dear friends, the best way to give ketamine is either intravenous or intramuscular or subcutaneous. However, this requires monitoring. With regard to intranasal, although it is 45% is the best bioavailability, hence it's worth taking risk by providing this intranasal ketamine, which will be easy to administer in the OPD basis. So to summarize the bioavailability, intravenous is high, next is intramuscular and subcutaneous, intranasal is 45%, oral and rectal is very less bioavailability. So my dear friends, ketamine either it is given intravenous or intranasal at this point of time, my dear friends. Let's understand how ketamine IV administration is done. Ketamine hydrochloride is administered at a dose of 0.5 mg per kg body weight. In certain few cases, you may have to increase the dosage to 0.7 mg per kg body weight may be required in severe resistant cases of depression. This 0.5 mg per kg body weight need to be diluted in 100 ml of 0.9% saline, and it has to be administered over a period of 40 minutes in an intravenous pump. Usually, ketamine antidepressant effect starts within 30 minutes to 60 minutes and lasts for 1 to 2 weeks, my dear friends. Ketamine is given 2 to 3 times a week. Usually, 4 to 6 ketamine infusion is all that is required to break the treatment resistance. If they do not respond for 6 infusion, either you can take a risk of increasing the dosage to 0.7 to 1 mg per kg body weight, or else you can term it as a failed trial of ketamine. However, few patients may benefit for more than 6 infusion with higher dosage, as I mentioned. Some patients may require maintenance ketamine, that is monthly once or twice ketamine for longer duration. Here, the success of ketamine treatment depends upon choosing the right patient for ketamine infusion is very crucial. Failure of at least 2 antidepressant is a must. Whenever there is a need for rapid resolution of symptoms with regard to depression and suicidal ideas or thoughts, ketamine should be chosen. Patient should not have any psychotic features, and whenever there is a suicidal idea, suicidal attempt is there, ketamine should be chosen even in emergency department or on OPD basis. Here, the ketamine is usually given on OPD basis is intranasal, inpatient basis invariably IV. Based on the symptom, severity, and choice of the patient, the ketamine can be given either in the inpatient or outpatient, and however, professional discretion plays a very important role. Suicidal attempt or ideation is an indication for inpatient care, my dear friends. However, if the patient refuses to admit, then you need to apply mental health legislation, whether the person has capacity or not. Would you like to section the patient? On that basis, you are going to decide whether you are going to give ketamine either inpatient or outpatient. OPD basis ketamine infusion is becoming very popular nowadays, my dear friends. However, intranasal OPD basis is very easy to monitor. Dose of ketamine is sub-anesthetics, that is 0.5 mg per kg body weight, my dear friends. However, certain patient may require higher dosage. And infusion, if you are doing, it has to be done in a hospital setting. Wherever emergency tray is available, emergency medications are available, where the healthcare professional such as psychiatrist has undergone advanced cardiac life support training, and other various anesthetic agents, muscle relaxant, adrenaline, dopamine, and various emergency medications are available. In such a scenario, only the ketamine administration to be done. That means ketamine has to be done, infusion has to be done in a hospital setting. Let's discuss about the ketamine intranasal administration. Spravato is the trade name for esketamine available for intranasal usage. It is available as a 2 dosing kits. The one dosage is 56 mg, the other kit is 84 mg. Each kit will deliver 2 dosages, that is 50% each. 56 mg kit will provide 2 doses of 28 mg each. Similarly, 84 mg will provide two doses, that is 42 mg of each dose, that is for each nostril. Medicine should be taken under the supervision of doctor in OPD or in inpatient. Each device contains two sprays with regard to 50% in each of the spray. Nil orally for at least 2 hours before you take this drug intranasally. Before taking the drug, the patient is asked to gently blow the nose to clear the nostril. Patient should hold the device upright between the thumb and the first two fingers. The patient need to tilt the head slightly back, insert the device tip into the nostril, close the other nostril. Firmly, the plunger should be pressed all the way. Repeat the same step on the other nostril also. The starting dosage on the day 1, the dosage will be invariably 56 mg, that is 28 mg on each nostril on day 1, followed by either 56 or 84 mg taken 2 times per week. That is, the dosage will be given up to 4 weeks, my dear friend. That means 8 dosages will be given over the period of next 1 month. Then, either based upon the response or the side effects, the doctor may prescribe 56 mg or 84 mg taken once a week over a period of next 5 to 8 weeks, my dear friends. Then, again, based upon the response or the side effects, the doctor will either prescribe 56 or 84 mg every 2 weeks, that is once in a 2 weeks, or a once a month can be chosen. But however, after each dosage, patient should be observed for next 2 hours inside the OPD. Now the question is, should a concomitant antidepressant or the other medicine should be given? Do not stop antidepressant during ketamine administration except MAO, my dear friends. You can also start a new antidepressant along with the ketamine administration. There is no contraindication at this point of time. Before you start ketamine, you need to do a thorough workup, that is, detailed evaluation, chief complaints and history of presenting illness, treatment history, what are the drugs which have failed, adequate dosage, adequate duration need to be documented, personal history, past history, family history, premorbid personality, general physical examination, look for any comorbidities such as hypertension, diabetes, mental status examination, cognitive function, suicidal ideas, diagnosis, basic investigation has to be done, and to quantify the severity of the illness, you need to do certain scales to be administered. The following parameters need to be monitored, that is ECG, echo, X-ray, biochem, hemogram, LFT and RFT. This investigation should be based upon the patient's age, comorbidity, medical conditions, cardiac conditions. On that basis, you need to give the investigation. Do not give the investigation blindly. Based upon the patient's comorbidity only you have to choose. However, whenever you give ketamine, oxygen saturation can be monitored. Diagnosis, assessment, and before you give ketamine, you need to take written informed consent, my dear friends. Let's look into the ketamine assessment. Here, before you give ketamine, you need to do certain important assessment, such as choosing the appropriate patient. Before you give ketamine, you need to make sure at least 2 antidepressants have failed. And you need to know whether the patient has any medical comorbidity. Baseline measurement of the severity of the symptoms is very essential. Vital assessment such as BP, respiratory system, ECG, echo, such of the investigation should be done. However, one need to be very careful with regard to vitals when you give ketamine on OPD basis. Patient should be monitored until he becomes stable after the intranasal ketamine administration. You need to look for cardiorespiratory stability, clear sensorium, attenuation of dissociative symptoms, and psychotomimetic effects. Patient should also have a reliable transportation system when he is going back after the administration of intranasal ketamine. He should not drive on his own. Operating heavy vehicles or machines are hazardous to the patient and to the public at large because ketamine can cause disorientation at times, my dear friends. Let's look into the drug interaction. We need to be very careful when benzodiazepines are given along with the ketamine. Invariably, it will be very difficult to titrate and it can delay the effect of ketamine because both acts on the same receptors. Lamotrigine decreases the glutamate, whereas the ketamine increases the glutamate. Hence, the effect of ketamine decreases with lamotrigine. Memantine blocks the NMDA receptor. That is again, the competitive will be there with regard to ketamine. Lithium enhances the ketamine activity. Dexamethasone, St. John's wort, induces cytochrome enzymes, which break down the ketamine very fast. Hence, whenever the patient is on these drugs, you need to monitor the drug or else stop this drug, and then only you need to consider giving the ketamine because each milligram of ketamine has a different effect on the patient. And also, the side effect profile need to be considered, my dear friends. Let's look into the comorbid conditions. Ketamine should not be given whenever there is a psychosis, severe hypertension, heart disease, severe diabetes, liver or kidney disease, and if the patient has multiple substance dependence and he is in a acute withdrawal or in delirium, my dear friends. To conclude, ketamine is an NMDA receptor antagonist and it is a rapidly acting antidepressant with a proven efficacy. It is administered as a sub-anesthetic dosage, that is 0.5 mg per kg body weight. Ketamine can be administered through various routes such as IV, IM, subcutaneous, intranasal, and also orally. Mechanism of action of ketamine is not clearly elucidated at this point of time with regard to psychiatric illness. It modifies certain functional brain connections, enhances synaptogenesis, and also enhances neuronal plasticity and glutamate modulations, my dear friend. Ketamine infusion is 0.5 mg per kg given 2 to 3 times per week in a 100 ml, 0.9% of saline infusion. Intranasal is given either as a 56 mg or 84 mg per sitting. Choosing the appropriate patient, monitoring the administration of the ketamine is very essential. Administer either IV or intranasal ketamine in a hospital setting, my dear friend. Thank you very much for your valuable time. Stay safe.